let's move on to some of the other data that's emerged. Next, talking about two trials that have looked at combining immunotherapy with chemotherapy in an unselect group of patients in the advanced stage setting. Haas, you want to walk us down 021G and maybe the 189 story that's beginning to unravel?
Sure. So we participated in the KEYNOTE-021. So this is a larger study with multiple cohorts, and the one that we're going to concentrate on is now famous cohort G subpopulation. So this ended up being a randomized phase 2 design after going through all the other cohorts for patients with non-squamous non-small cell lung cancer. It was unselected based on PD-L1, so everybody could get in. And the randomization was simple. We would use the standard carbo pemetrexed followed by maintenance pemetrexed versus the same backbone with pembrolizumab grafted onto the platinum doublet given every 3 weeks. I have to admit, and I have said this before, personally I was a skeptic that adding cytotoxics to checkpoint inhibitors would be a reasonable strategy. I didn't really anticipate positive results that we've seen, but nonetheless, obviously I'm proven wrong. So 60 patients roughly per arm were recruited. I got to tell you again, because we put a number of patients in this study, well-tolerated regimen, I really didn't have any major issues managing patients on this. So at the time of first reporting that Dr. Langer did at ESMO and subsequent publication in Lancet, PFS and response rate was superior in the group that got the triple therapy as opposed to the platinum doublet. Crossover was allowed such that if patients on chemo arm had any evidence of progression, they were allowed to get additional pembro and all of that. So the PFS and response rate made this an interesting combination, and the PFS improvement was quite significant. We don't really have data in terms of PFS improvement based on level of PD-L1 because the subsets were so small that it would have been really difficult to have any logical conclusions drawn from these smaller subsets. But what I think is even more surprising is that with further follow-up, overall survival started trending towards the triple combination. Now, that analysis that I presented at the World Lung just last year doesn't have the statistical power behind it because alpha was spent for the primary analysis, but nonetheless, you see a separation of the curves, perhaps suggesting that chemotherapy can add to the additional benefit we see with PD-L1 or PD-1 inhibition. The interesting part, again, is that it does not seem to be necessarily right now depending upon the level of PD-L1 expression. And then we have a press release that the exact design, but in a phase 3 format, KEYNOTE-189 is positive for both PFS and OS. Obviously, I haven't seen the data, so I can't really tell you what it really shows or whether there are subgroups that are benefiting more. Is the overall survival driven, for instance, because of the high PD-L1 subgroup or not? We don't have any of that data, but I think this study, along with what we're going to discuss next in POWER, sort of makes you wonder if the addition of chemotherapy can at least have additive effect, if not synergistic, to the checkpoint inhibitors that we're using right now. So interesting results. I would not have predicted the overall survival advantage, but here it is, and I think it's becoming part of what we're using because based on a phase 2 study, FDA has approved the triple combination, as we know, so it gives us an additional option for patients who come in without molecularly driven tumors.
Okay, excellent summary. I have a lot of questions.